Well, good afternoon. Just to put things in context, we're talking about bypass in the setting where venous conduit is not available, greater saphenous vein, because, PK loves me and always gives me an easy one. My disclosure is no AI was used in the creation of this content. So endovascular therapy has rightfully challenged surgical approach to the femoral segment. We all know that the increase is about 25%, and there's a decrease concomitantly in surgical approach to femoral disease. And particularly in this room, I think in this panel, every patient is an endovascular candidate. Some are better than others, for sure. So let's set some context. First and foremost, we're talking about claudication. So the first thing that comes to my mind when I hear the word intermittent claudication is this. Now, we, Society for Vascular Surgery, do indeed recognize the need for treatment of claudication when things have failed. And I think everybody in these live cases today have done a formidable effort in showing that there was a very serious attempt to medical therapy. The second component of the claudication management is it has to be durable for at least 2 years to actually improve functional outcome. We also think that in terms of when you're considering revascularization, you have to talk about MACE, you have to talk about male, without a question. And I'm not quite sure how good we're doing that job, because patients just want to walk better. So there is also a reminder that infrapopliteal or asymptomatic patients should never be approached in the setting of PAD interventions or when they have claudication with infrapopliteal disease. Now, this is a focus update, which is actually in press right now, and you can see there to the right side of this forest plot all the MACE, so we can learn to actually make sure we're not intervening on patients who have a higher risk of MACE. We also can learn about males, and specifically we can address the issue of amputation. Now, in general, amputees are secondary to critical limb-threatening ischemia, and we recognize that is actually sometimes even an option of care. But in claudication, it shouldn't really be even an option for these patients. But you can see that when we intervene, there's actually some predictors of amputation in this particular setting. So you can see about in a large cohort of patients, a 1.3% amputation rate for PVIs and a 2.1% amputation for bypass. So certainly a cautionary tale when we're intervening in claudicators. And you can see here the predictors of those two things. So in conclusion, we may be harming patients when we do interventions for claudication. We're not selecting purposely. And I think we all know that. I can go on and on about the negative outcomes for claudication management interventionally when we do not follow a very rigid approach. But having said that, there are going to be patients who have problems after interventions who don't have greater saphenous vein available. So we're really talking about peripheral vascular interventions presenting failure of peripheral vascular interventions presenting with intermittent claudication. Now, the Society of Vascular Surgery actually ran 2,280 unique scenarios in different segments of the vascular tree with a very low inter-observer variability, and you can see the rating panel reflected here with all the societies. And of course, PK chose this topic because we don't have any rated recommendations from the Society for Vascular Surgery. So I think he wants me to. And on top of that, in terms of approach to failed peripheral vascular interventions, we can do redo interventions like we just saw in live cases. PTAB is certainly something that is, on its infancy. And there is also open surgical bypass. And I think I was told to talk about not adequate greater saphenous vein because a greater saphenous vein available conduit will be an easy answer. So for you in your debates, I think really it's not too much of a debate. When you have greater saphenous vein available, probably that's the right choice, unless the patient is obviously a high morbidity, mortality risk patient. So collectively, not adequate greater saphenous veins are known as alternative conduit. There are a bunch of them, but we're going to concentrate specifically on the PTFE. Now, PTFE has evolved. Conduits have evolved. The conventional PTFE is no longer. We have endoluminal modifications with heparin bonded. We have structural modifications with sutureless anastomosis available to us to come and help our patients as well. So back then, 3-year data, 58%, 39%, 5-year data. Today's data, 5 years, 59, 60% data. We also learn predictors of failure of bypass, of PTFE specifically bypass. Runoff score, very good outcomes. Above knee targets, incredibly good outcomes. Large diameter vessel when we use the off-the-shelf conduit, very cheap by the way. 8mm conduits is what we should do, excellent outcomes as well. So all these are predictors of positive patency for PTFE grafts in claudication setting. So there's about 8,435 surgical procedures a year, open surgical procedures a year for claudication in this country. And, you know, the detour just arrives about 1,000 cases, so 250 a year or so. So as you can compare the primary patency at 36 months for the detour data, very small series of patients, 58% or so, versus PTFE, which is about 68%, 70% of 36 mark. Now, I found myself asking what, PK does. And I found what he does. And in the publications, they actually choose only to use detour in critical limb threat ischemia, not in claudications. And you see a 3-month patency data of 80% and a graft thrombosis, a deep venous thrombosis of 12.5%. So, personally, I will not exploit the youth and experience of the detour system for the purpose of this debate. I think in conclusions, you have to be selective in managing claudication. I think PTFE bypass is still a viable option, although I do prefer great esophageal vein, but PK didn't let me talk about that one. Thank you very much.